Good.
अरे पेपर में
So a very good morning to everyone. I, Dr. Poonam Joshi, welcome you all to our Head and Neck Actor class series. So our today's presenter is Dr. Tejpal Gupta sir. Sir is professor in Department of Radiotherapy, Dta Meta-Analysis, ACTREC, Mumbai. This paper which sir is going to present is basically published by him by himself, and it is a very sought out paper with very good number of citations, and the topic is diagnostic performance of post treatment FDG PET CT imaging in head and neck cancer, a systematic review and meta analysis. So I welcome Dr. Tejpal Gupta sir. Sir, please go ahead with your presentation. Hello. Hello. Are you there, sir? Hello. Hello. We are sorry for this. I think sir is finding some problem in joining. Just give us 2 minutes.
थोड़ा और एक बार खोल ले, एक लड़ और खोल दे, नहीं पूरा नहीं, एक
Hello, am I audible now?
Yes, sir, you are audible, sir.
I don't know what the, sorry, I don't know what the issue was with the link. So can I just share my screen?
Yes, sir. Please.
I think you'll have to make me a co-host for me to share the screen.
IT, please help sir with the sharing of the screen. Hello.
I can, let me just.
So you can directly share.
So, this has started, sir. You start.
Yeah, I'm just opening the presentation. Yeah, is the
Yes, sir.
first slide visible
yes,
now?
It is visible.
Yeah.
Yes.
I'll just make it full. Yeah.
Yes, sir. Just fine, sir.
Okay. Again, apologize for issues with logging in and sharing the screen. So I think Poonam asked me to talk on the systematic review and meta-analysis of post-treatment FDG PET in head neck cancers, and I thought I will slightly broaden the topic, and I have reworded it as an evidence-based approach. So first, we'll basically discuss what our experience was with using post-treatment FDG PET in head and neck cancer in one of the trials that we did, and how did we then go on to do evidence synthesis using systematic review and meta-analysis, and then go to what other evidence is there in terms of the utility of post-treatment FDG PET in head and neck cancers, and finally end up with some templates or scoring for the post-treatment FDG PET in head and neck cancer. So there are several potential applications of PET-CT in head and neck cancer, and today what we will be focusing is the one circled in red, which is the response evaluation early detection of recurrence. So we all know that head and neck cancer is a common problem, more so in the developing countries, and definitive radiochemotherapy is the contemporary standard of care in the non-surgical management of head and neck cancers. And over the last decade or so, conformal techniques like 3D CRT and IMRT have become the established paradigm as far as radiotherapy is concerned. Response to definitive radiochemotherapy is an important predictor of local and regional control. And we realize and understand that conventional imaging such as CT scan or MRI have suboptimal accuracy in the post-RT setting. And the functional imaging with FDG PET-CT, there is a potential for improved assessment. Accurate response assessment is crucial for decision making, as early detection of residual or recurrent disease is central to successful surgical salvage in head and neck squamous cell carcinoma. As I said, the conventional imaging such as CT or MR for response assessment following definitive radiochemotherapy has suboptimal accuracy, and you can see this review combines several such studies that looked at either the CT or MR or a combination of CT and MR, and you will see that the sensitivity and the specificity both are suboptimal, quite low. So there is clear data to suggest that the diagnostic performance of CT or MR for response assessment following definitive radiochemotherapy is not at all an acceptable thing. It's quite low. So what happens with FDG PET? How does the uptake decline in the lesion, either in the primary site or in the neck nodes following radiochemotherapy? One, of course, there is decrease in the tumor burden, so lesser number of viable tumor cells. With radiation, the proliferative potential of the tumor is also significantly reduced. So there is reduction in intracellular metabolic activity, and it leads to shutdown of glucose metabolism. And we all know that FDG avidity depends on the transportation of the GLUT receptors from the membrane to the cytosol. So that is why the metabolic activity or the glucose metabolism significantly reduces following definitive radiochemotherapy, and that is what can be assessed quite nicely with the FDG PET following definitive radiotherapy. So we asked this question quite early on in the early 2000s, that what is the diagnostic performance of post-treatment FDG PET in patients of head and neck cancers treated with definitive high precision radiochemotherapy. So this was done as part of a IEC approved prospective study. Standard acquisition of PET-CT after injecting 370 megabecquerels of 18 fluorine fluorodeoxyglucose. CT also acquired along with that, and PET data reconstructed using 3 min bed positions. All this is pretty much standard. And the fusion of PET and CT was done using an inbuilt software, and SUMAX were calculated on the regions of interest separately for primary site and neck nodes. So this is a typical FDG PET CT that you would see. These patients were treated with high precision definitive chemoradiation. I will not go into the details. All were treated with either 3D CRT or IMRT using 70 gray, between 50 to 70 gray. Low risk volume received 50 gray, high risk volume received 70 gray, and all these patients, those who were fit, received weekly cisplatin 30 milligram per meter square. This is a typical dose, wash, and DVH. The FDG PET was done for all these patients at baseline as well prior to radiotherapy, and then at response assessment. In the protocol, we had put 8 to 12 weeks after completion of chemoradiotherapy. The minimum follow-up of all these patients was at least 1 year after the response assessment scan or till failure or death. Any focally increased asymmetric uptake of FDG was scored as positive. Assessment was based on a joint interpretation between the nuclear medicine physician and the clinician, and we calculated the standard metrics of response assessment, which is the sensitivity, the specificity, the positive predictive value, and the negative predictive value, and overall diagnostic accuracy. The reference standard was pathological findings or clinical follow-up data. So just to sort of recap for everyone, the standard metrics of diagnostic test accuracy are sensitivity, specificity, the NPV, and the PPV. And typically, we denote them as TN, TP, FN, FP, which means true negative, true positive, false negative, and false positive. So we accrued a total of 60 patients on the study. 2 patients refused post-treatment imaging, and 1 died within 4 weeks of chemoradiotherapy. So the response assessment FDG PET CT was available in 57 patients. The median time to imaging was 9 weeks, and with an interquartile range of 8 to 12 weeks. We saw positive, or we scored response assessment FDG PET as positive in 12 patients. 8 of them had primary site positivity, and 6 had positivity at the neck nodes. Some of them had positivity at both sites. That is why it is 12 patients, but 8 at primary site and 6 at the neck node. And the median follow-up was 24 months for all patients and 26 months for survivors. So this is just the demographic data, predominantly oropharynx 50% and rest for hypopharynx and larynx. Predominantly again stage 3, stage 4. There were only 15% patients which were stage 1 and 2. So this is the SUV max. This is the box plot showing the SUV max pre-treatment for the primary site on the left, and the post-treatment for the primary site on the right of the first box. And for the neck, pre-treatment SUV max on the left side of the second box, and post-treatment SUV max on the right side of the treatment box. So significant decline in SUV max following definitive chemoradiotherapy, something that you would generally expect. This is an example from the study where there was increased uptake in the left tonsil and left 1B node. Following definitive chemoradiotherapy, there was complete response at the primary site, but there was persistent uptake in the node. So the patient underwent a salvage neck dissection, and on salvage neck dissection, there was a grossly metastatic lymph node with PNE. All other 15 nodes were negative. Around 6 months later, this patient had a submucosal bulge seen in the left tonsillar fossa. Repeat FDG PET showed uptake at the primary, which was positive on biopsy. So if we now look at the first response assessment scan of this patient, so it was true positive for the neck, because the neck was showing a residual node, and on neck dissection there was viable disease with extranodal extension. But this PET scan had also showed complete response at the primary site, but within 6 months of MND, a local recurrence was detected, which means the first response assessment scan was false negative for the primary site. So it was true positive for the neck, but it was false negative for the primary. So these are the metrics of sensitivity and specificity. So positive predictive value and negative predictive value separately for the primary site, the neck, and combined primary and overall. So you can see that the negative predictive value for the primary site and neck were more than 90%. The positive predictive value for the primary site was pretty low at around 50%. We also looked at whether this predicted outcomes, and patients with PET positivity, even if they were falsely positive, had a worse outcome than patients with PET negativity. So it appeared that the post-treatment FDG PET CT status was also a predictor of loco-regional control and survival. So this was published in the year 2010 in the Green Journal, where we concluded that post-treatment FDG PET-CT has the potential to detect residual recurrent disease when it is conventionally undetectable. It has low to moderate sensitivity but high specificity. The positive predictive value is quite suboptimal for the primary site, and you should always correlate that with biopsy. However, exceptionally high negative predictive value both for primary site and neck, and that should be used to guide the decision making. And FDG negativity at post-treatment setting is potentially a prognostic factor for outcomes. Then we went on to think, how can we make this evidence more robust? Because FDG PET had gained quite immense popularity in between 2005 to 2010. Numerous studies had been published after the IELTS meta-analysis. There was conflicting evidence in the index medical literature. PET had also seen tremendous technological and methodological improvements over time. And now we had more modern and robust statistical tools for doing systematic reviews and meta-analysis. So we decided to go ahead with a systematic review and meta-analysis of all the available data till that time to generate the current best evidence. So just to briefly talk or introduce what a systematic review is, the formal definition is that it's a summary of the medical literature that uses explicit methods to perform a thorough literature search and critical appraisal of individual studies, and that uses appropriate statistical techniques to combine these valid studies. Most of the time, most people do a systematic review for effectiveness of therapy, but increasingly systematic reviews of diagnostic test accuracy are being done, and they are also quite important. Systematic reviews are systematic in the identification of literature, explicit in statement of objectives, materials, and methods, and reproducible in methodology and conclusions. And the best individual source of systematic reviews is the Cochrane library. Fortunately, we are Tata Memorial Center is an affiliate of the Cochrane India Network, which is a part of the global Cochrane network, and the Cochrane library is available to us through the Tata Hospital website. Now, what is a meta-analysis? This term was first coined by Glass in 1976. It is a quantitative synthesis of data to produce a overall estimate, generally done as part of a systematic review. It is a statistical method that combines results of several independent studies. Again, the formal definition is a statistical analysis of the results from independent studies, which generally aims to produce a single quantitative estimate of the effect. Now, what actually happens in a meta-analysis? The main outcome is the overall magnitude of the effect. It's not a simple average of the magnitude. Meta-analysis gives more weight to studies with more precise estimates. The weighting factor is almost always 1 by square of the standard error. And the standard error is generally the expected variation in the effect if the study was done again and again. Other things being equal, this weighting is generally related to the study sample size. So larger the sample size, more would be the weight accorded to that particular study in the meta-analysis. But the weighting factor also takes into account differences in error of measurements between studies. So a more precise study would have a higher weight, even if the sample size was less. So how do you go about conducting a systematic review? Formulate a research question. For the Cochrane, you need to register the title. For other reviews, registration of the title is not mandatory. You write a protocol, locate and select the studies, assess the studies for the risk of bias, extract data, relevant data from the study, analyze and present the results, interpret the results and write the systematic review. And for Cochrane, again, it is required to update, periodically update the review. So how did we go about doing the DTA meta-analysis, which is that DTA stands for Diagnostic Test Accuracy. As I said, you need to use the PICO approach. PICO stands for patients or participants, intervention, in this case, the index diagnostic test, comparator, which is the reference standard that you would use, and outcomes, which is like disease or known disease for the diagnostic test accuracy methods. So the participants or patients here were head neck cancer patients treated with definitive treatment, radiochemotherapy. The index diagnostic test was the post-treatment FDG PET-CT. Our reference standard was the either biopsy or cytology in case of neck nodes or clinical follow-up. And the outcomes were whether disease is present or not, and that you generally get for diagnostic test accuracy methods by drawing a 2x2 contingency table, true positive, false positive, true negative, and the false negative. So this is what a 2x2 contingency table would look like. Whether disease is present or absent, and whether the index test is positive or negative. Sensitivity, again, we recap: true positive divided by true positive plus false negative, whereas specificity is true negative divided by true negative plus false positive. So this is the most important part of doing a DTA meta-analysis, that you have to have your 2x2 contingency table quite nicely tabulated. Just a brief mention of a threshold effect in diagnostic testing. So decreasing threshold increases the sensitivity but decreases the specificity, and the other way around. If you increase the threshold, that decreases the sensitivity but increases the specificity. Just something that you need to remember. Also, all diagnostic accuracy studies have to be assessed for quality. And back in 2003, QADAS tool was published to assess the quality of the diagnostic accuracy studies. Subsequently, it has been improved. There is a QADAS 2, which was published in 2011, and now all diagnostic test accuracy studies have to use the QADAS 2 for quality assessment. So how did we do? We did a systematic search of the medical literature from 1990 till 2010. We had explicitly defined inclusion and exclusion criteria. We used a standardized data extraction sheet, and 2 reviewers extracted the data independently. That was randomly verified by a 3rd reviewer, and any discrepancy was resolved by consensus. We extracted data separately for the primary site and neck nodes. Data from individual studies were summarized in a 2x2 table. They were classified as true negative, true positive, false negative, and false positive for pooling the meta-analysis. We used the random effects model and calculated a weighted mean pooled sensitivity, specificity, PPV, and NPV with 95% confidence interval. We also did something known as a symmetric receiver operating characteristic curves fitting using inverse variance methods. Heterogeneity was explored through hierarchical summary receiver operating characteristic curves using Bayesian methods. And we also did meta-regression to study the impact of timing and study quality on diagnostic accuracy. And all of this was done on a few softwares. MetaDisk is a very common software for diagnostic test accuracies, but we did some of the meta-regression and the curve fitting on Stata. So this is how the results were. We identified 51 unique studies totaling 2,335 patients. 24 studies reported on primary site, 30 studies had reported on neck nodes, and combined primary and neck 17 studies had reported. Overall, based on QADAS, the quality of primary studies was reasonably good. The median QADAS score was 11 with a range of 7 to 13. So this is in a sense the result from the diagnostic test accuracy meta-analysis. So as I said, we did it separately for primary site, neck node, and combined primary and neck. So this is for the primary site. As you can see, the weighted mean pooled sensitivity was 0.80 with a 95% CI of 0.74 to 0.85. The specificity for the primary site was 0.87 with a 95% CI ranging from 0.85 to 0.90. The positive predictive value was again low for the primary site, 0.59. However, the negative predictive value was again exceptionally high. The weighted mean pooled estimate was 0.95 with a 95% CI ranging from 0.93 to 0.96, which is excellent as far as any diagnostic test is concerned. For the neck node, the sensitivity was 0.73, the specificity was 0.88. Again, the positive predictive value was quite low, 0.52, but negative predictive value was again exceptionally high, 0.95. 95% CI ranging from 0.93 to 0.96. If we combine primary site and neck, the sensitivity and specificity was 0.88 and 0.88 respectively. The positive predictive value was marginally better, but again not very good, 0.76. But NPV was again quite good, 0.94, 95% CI ranging from 0.92 to 0.96. As I said, we did the summary receiver operating characteristics curves. On the left is the primary site, on the right is the neck nodes, and as you can see, the area under the curve, the higher the area under the curve, 1 is ideal. You will never get that for any test. We got an AUC of 0.91 for the primary site and AUC of 0.86 for the neck nodes. Anything above 0.85 or 0.9 is considered acceptably high. This is the quota summary plots. As I said, most of the studies had reasonably good quality with a median score of 11. On meta-regression, we used certain covariates. The covariates were the timing of the scan, the quality of the primary studies, quota score stratified by quota score less than 11 versus more than equal to 11, and whether only FDG PET was done or it was the scan was done on an integrated FDG PET CT. So what you can see is that the timing of the scan had an impact on the diagnostic accuracy, and scans that were done beyond 12 weeks or more had a higher accuracy as opposed to scans that were done within 12 weeks. And this stood out for neck nodes. It did not stand, it was not statistically significant for the primary site, but for neck nodes, the timing of the scan was had a significant impact on the diagnostic performance of the scan. What are some of the caveats and limitations? The search that we did of the literature was limited to English language and PubMed Medline. There may have been duplication of data. Some studies reported both on primary sites and neck nodes separately and combined. Some studies reported initial experience followed by long-term results. We did not use the quality score on quotas for weighting in the meta-analysis. A formal assessment of publication bias was not done, and there was evidence of significant heterogeneity. And although we do the random effects model, you cannot really take away the heterogeneity aspect from the results. So there is a potential for bias and influencing results, and that is, one has to always remember the limitations when we do such kind of systematic reviews and meta-analysis of primary studies. So this was published in the European Journal of Nuclear Medicine and Molecular Imaging, and what we concluded was that overall diagnostic performance of post-treatment FDG PET CT for response assessment and surveillance imaging of head and neck cancers is good, but its positive predictive value is somewhat suboptimal. Negative predictive value remains exceptionally high, and a negative post-treatment scan is highly suggestive of absence of viable disease that can guide therapeutic decision making. The timing of post-treatment imaging has a significant, though moderate, impact on diagnostic accuracy. So this is what we concluded. This was in 2011. Now moving to, is there any higher quality evidence, or is there any randomized controlled trial based on response assessment PET CT? And there is one. This is the UK PET neck study, where Hisham Mehana and colleagues looked at PET CT surveillance versus neck dissection in advanced head and neck cancers. It was quite a routine practice in several parts of the world for any patient with N2 plus disease at index diagnosis following definitive radiochemotherapy. Many patients would undergo a planned neck dissection, even if there was a complete clinical radiological response to definitive chemoradiotherapy. And that practice was quite firmly entrenched in several parts of Europe and UK. And this study was an important and landmark study in that sense that it challenged that practice, and now it is no longer, planned neck dissection is no longer the standard of care anywhere in the world. So more than 550 patients were randomized, half of them to the surveillance group and the other half to the planned surgery group. All of these patients were N plus at index diagnosis. So those who underwent PET CT surveillance, many of them had a complete response, but some of them had a partial response. Nearly 70% of the patients had complete response on PET CT. And overall, a total of 54 neck dissections were done on the surveillance arm because of either residual disease or equivocal PET scans. As far as the control arm, which was the planned surgery group, 221 neck dissections were done in the planned neck dissection group. And what did they find? Quality of life comparison, there was no difference in longitudinal quality of life between the two groups. More importantly, PET CT surveillance was non-inferior to planned neck dissection as far as overall survival is concerned. The hazard ratio of death was 0.92 with a p-value of 0.004 for non-inferiority. So the hypothesis was that PET CT guided neck dissection would be non-inferior to planned neck dissection in patients with node positive disease treated with definitive radiochemotherapy. So this trial clearly established the non-inferiority of PET CT surveillance, and since then neck dissection is now based in all guidelines on the post-treatment response evaluation following definitive radiochemotherapy in head and neck cancers. So neck dissection now should be guided by the post-treatment response assessment PET CT. Now, has newer evidence been generated moving the field forward in the last 1 decade? As I said, we published the meta-analysis in 2011 and more than 10 years have elapsed since then. So yes, there are a couple of more meta-analysis. This was published in 2015, where they looked at diagnostic accuracy of FDG PET or PET CT in patients with head and neck cancers. Again, you can see that the pooled estimates of sensitivity and specificity are in the high 80s, and the SROC curve is also showing good area under the curve. What they did also show was that there was modest improvement in accuracy with delayed PET CT. So PET CT done between 4 to 12 months after treatment versus done more than 12 months after treatment, there was a modest improvement in accuracy with the delayed PET CT. And some guidelines actually now recommend doing a PET scan again at 1 year. So you do an initial response assessment PET scan at 12 weeks, between 12 to 16 weeks, and then do a repeat interval scan at 1 year, which will improve the negative predictive value even further, close to a 99% negative predictive value if the 1 year post-treatment PET scan is negative. A more contemporary meta-analysis published a couple of years ago. So they also looked at systematically at the index medical literature, and what they also found was that the area under the curve was quite high. What they also demonstrated was that there was a difference in diagnostic accuracy based on the pre-test probability of having residual disease at the primary site or the neck. Importantly, what they also showed was that the accuracy was somewhat lower in HPV associated oropharyngeal cancers, and that was because many a times with the HPV positive disease, the nodes tend to shrink slowly, and you have to allow a much longer time for the morphological remission of the neck nodes. This is a review article on the diagnostic performance of post-treatment PET CT in head and neck cancers stratified by the HPV status. And there are some differences between HPV positive and HPV negative patients. And this was recently meta-analyzed by a group where this is a very recent article published very recently in just last month, I believe, looking at post-treatment PET CT in HPV associated oropharyngeal cancer. And what you can see are the estimates of sensitivity and specificity. There is what they concluded was that there is a low risk of failure if the PET CT is negative in HPV positive oropharyngeal cancer, which is quite reassuring. What they also demonstrated was that although patients with positive PET CT have high failure rates, the rates of biopsy proven cancer remain low, indicating again suboptimal positive predictive value even in the HPV positive cohort. So despite getting a positive PET scan does not mean that all those patients will be true positives. There is particularly in HPV associated oropharyngeal cancer, you have to be really careful. The failure rates, the biopsy proven cancer rates are much lesser than the PET positive rates. So that is something that one has to bear in mind even for HPV positive oropharyngeal cancer. Now, is there a role of doing PET surveillance in post-op setting? There is very limited data on surveillance PET CT after surgery. Currently, it is not routinely recommended to do after surgery, but only for suspected recurrence. This is one study that I could find published in oral oncology, where they looked at an interval PET scan 3 to 6 months after completion, after surgery, with or without definite post-operative adjuvant radiotherapy, chemotherapy. So going by the numbers, this looks quite encouraging. The negative predictive value was very high, 99%, and the area under the curve for detection of any site of recurrence was also high, 0.96. But most guidelines do not recommend doing a routine post-treatment PET, FDG PET CT in the post-op setting. There's very limited data on the value that it brings to the outcomes of patients. Now, coming to the last part, the post-treatment assessment of the FDG PET, there are certain soft criteria. The criteria that we used in our primary study analysis, which was published in the Green Journal, was that moderate to high intensity focal uptake and asymmetric uptake is likely to represent residual or recurrent disease, whereas minimal to mild FDG intensity, diffuse uptake, and symmetrical uptake is largely post-treatment changes. However, these above criteria indicate only a probability and are not a certainty as far as post-treatment assessment is concerned. So can we improve the interpretation of the post-treatment FDG PET CT and make it more objective and reproducible? So several criteria have been proposed for that. This was one of the initial attempts. Sandro Porcedo from the Australian group actually proposed this criteria, where they gave a simple criteria, either considered negative or equivocal or positive. A negative when no residual activity above the background, positive when focal uptake corresponding to a structural abnormality greater than the background liver activity, and equivocal when it is greater than adjacent tissues but below the background liver activity. So this was a very simple criteria that Porcedo gave in 2011: negative, equivocal, and positive. This criteria was used for suspected residual disease in the neck nodes. This is a study from Tata Hospital itself. This was done, the comparison was with histopathology at neck dissection. So patients who had undergone neck dissection following a FDG PET CT, the PET CT was either scored as positive or equivocal or negative, and then that was correlated with the findings on neck dissection. So this is the ROC curve. What we concluded from this was that, and we got an area under the curve of 0.874, which is quite good as far as diagnostic accuracy is concerned. And also the study defined the SUV max of 4.62 in the node as the most optimal cutoff for identifying residual disease. Generally, a SUV cutoff is not routinely recommended to identify residual disease either in the primary or the neck. But in this study, we did see that an SUV max of 4.62 was supposed to be the most optimal cutoff for identifying residual disease. This was published in Oris Meses Larynx in 2019. Another criteria that was proposed was the Hopkins criteria. This is a modification of the Deauville's criteria, which was extensively used in lymphoma. So they gave 5 scores: 1, 2, 3, 4, 5. 1 and 2 are likely negative, or mostly negative. 4 and 5 are likely to be residual tumor, and 3 was sort of equivocal, but more favoring post-radiation inflammation rather than disease. So this is just an example from the Hopkins, the Marcus paper that gave this Hopkins criteria. This was used by a multi-center prospective cohort study in the US, the Eclipse study, where they looked at the Hopkins criteria 12 weeks after CTRT in head and neck. And what they concluded was that the Hopkins criteria is a reliable tool to assess the response in head and neck cancer patients. However, it has a time-dependent lower sensitivity for late manifesting disease beyond 9 months. So the sensitivity is somewhat lesser when the disease manifests more than 9 months after completion of definitive radiochemotherapy. The most recent system that has come up in the last few years is the neck imaging reporting and data system, the NIRADS, which basically divides them into 4 categories. Category 1 is no evidence of recurrence. Category 2 is low suspicion of recurrence. Category 3 is high suspicion of recurrence, and Category 4 is definitive recurrence or pathologically proven recurrence. And these findings are linked to management recommendations. So they also tell you what should be the next sort of course of action once you assign the category 1, 2, 3, or 4 to the post-treatment neck imaging. This was published in 2016. So we have used this NIRADS template for a cohort of our patients treated on a prospective randomized trial comparing to radiotherapy fractionation schema, the HYPNO study. 200 patients were randomized on the study that were included for this NIRADS template analysis. 10 patients did not have a post-treatment FDG PET CECT due to various reasons. So this data set is now limited to 190 patients. We did 4 types of analysis. We looked at the association between the NIRADS categories and loco-regional recurrence. We calculated the metrics of diagnostic accuracy for the NIRADS template. We created an ROC curve to calculate the area under curve for the NIRADS template, and we compared the 2-year loco-regional controls stratified by the NIRADS categories. So this is a representative example from the cohort. So this was a patient who at index diagnosis had a avid mass in the left base tongue crossing midline with an ipsilateral neck node. 3 months after definitive radiochemotherapy, there was complete metabolic and morphological resolution of both at the primary site and the neck node. So he was assigned as NIRADS category 1 for both primary and neck. However, 1 year later, there was a new onset dysphagia for which he underwent a repeat or a restaging PET CT that showed up focal FDG avid lesion in the left base tongue. So essentially, there was a local recurrence. However, the PET did not show any obvious neck nodal involvement. This patient underwent a TORS and selective neck dissection, which confirmed the presence of poorly differentiated squamous carcinoma involving base tongue, but all the regional nodes were reactive. So the NIRADS categorization at the time of first response assessment scan was false negative for the primary, but true negative for the neck. This is the diagnostic performance of the NIRADS. So what we got was the sensitivity for combined was 84.4%. The specificity was 69.7%. Again, suboptimal positive predictive value 46.3. High negative predictive value 93.5, and overall diagnostic accuracy 73.2. The ROC curves are for primary site, neck, and combined primary and neck on the bottom panel. If we look at loco-regional control stratified by NIRADS category, so of course NIRADS 1 had the best loco-regional control, and NIRADS 3 had the worst outcomes. So what we conclude from this was that NIRADS template, which is an interpretative framework for post-treatment surveillance imaging using FDG PET CECT, is associated with good diagnostic performance and also has prognostic utility in head and neck cancers treated with definitive chemoradiotherapy. What about the performance of the NIRADS system from other publications? So this is a table just which summarizes all the recent data sets of the NIRADS system. The initial experience in the first few years has been mixed. The diagnostic performance has been somewhat variable, particularly the NIRADS 2. As you can see, the recurrence rates are much low in the NIRADS 1, around 5%. They vary in NIRADS 2 between 20 to 30%, and more than 50 to 60% loco-regional recurrence in NIRADS 3, which is expected. So NIRADS, although is a useful system, there is a variability in its diagnostic performance. To end, this is the recommended algorithm for management of node positive head and neck following definitive chemoradiotherapy. So you do a clinical evaluation at 6 weeks, a PET CT at 12 weeks, and depending on whether you get a PET, which criteria you use. I mean, basically either you use a NIRADS or CEDU or the Hopkins criteria. You can decide to do an interval PET CT if you're not very convinced that there is residual disease, and then take your decision based on the interval PET CT rather than the first post-treatment response PET CT. So in summary, definitive radiochemotherapy is the contemporary standard of care in head and neck cancers. Clinical assessment of response to definitive radiation is challenging. CT and MR have suboptimal performance in the post-treatment setting. FDG PET CT provides improved diagnostic accuracy of post-treatment assessment. It has a high negative predictive value, but suffers from suboptimal and low positive predictive value. The timing of the post-treatment FDG PET has a major impact on the diagnostic performance. Now we have high-level evidence for FDG PET CT guided neck management after definitive radiochemotherapy. The NCCN recommends FDG PET CT at or beyond 12 weeks after completion of definitive radiochemotherapy. PET positivity after radiochemotherapy is an independent adverse prognostic factor for outcomes. The accuracy and prognostic impact might be somewhat lower in HPV-associated oropharyngeal cancer, and Nirad's, particularly category 2, has variable diagnostic performance in post-treatment surveillance. I think I will end here, and I'm happy to answer any questions.
So thank you, sir. It was an excellent presentation. And I think if anyone has any questions, please post them on the chat box. Sir, in the meanwhile, I would just ask one question. I was just writing. So like you said that in our most of the routine, our practices, we see that patients usually, they come to us sometimes after the completion of post-CT-RT, they come with some symptoms like surgical patients, they come with symptom of cough, difficulty in breathing. That could be because of the post-RT, we know, or it could be because of the recurrence. So in those scenario, what should we do? Like in between 6 to 8 weeks, where we know the accuracy of PET CT won't be that great also. So should still we go ahead and do the PET CT, or rather we should just focus on a contrast enhanced CT scan?
So Poonam, one or two things which I want to actually make clear, particularly to the head neck surgical residents. I think many a times when the patient comes with symptoms, we tend not to do a detailed physical examination, including a scopy. I mean, I think that is much more important than doing an FDG PET CT. Time and again, it's written review with FDG PET CT. I mean, I think first is the clinical evaluation. If you are not able to do a clinical evaluation, that's a different matter. But I think most important for head and neck cancers is to do a thorough clinical examination, including a scopy if required. I mean, either a direct laryngoscopy or a fiber optic laryngoscopy. See, oral cavity is not that much of a problem because you can see pretty well in the oral cavity. But say a larynx and a pharynx, in either if you are not able to see through the Hopkins, you might need a fiber optic, I mean, do a microlaryngoscopy or assessment. Clinical assessment is more important than doing the FDG PET. We should certainly not do FDG PET within 6 to 8 weeks of the definitive radiochemotherapy. See, post-surgery, it's a different matter.
Yes.
Post-surgery, if some adjuvant treatment, suppose radiotherapy has been given, then again you will have to wait for at least 8 to 10 weeks, ideally 12 weeks only. But if suppose it is post-surgery, radiotherapy has not been done, and then the patient comes with symptoms, you are seeing some mass there or something, some ulcer there, then of course there is no need to wait. You can do a restaging PET CT because you will also have to rule out distant metastasis. The advantage of PET CT is that it is looking at the systemic disease burden as well. But I think clinical examination is very, very important. I have not put a couple of slides. I was actually thinking, should I put those slides? So clinical, the incremental value of FDG PET CT over a thorough clinical examination is actually very, very modest.
I think that was a very important point, sir, which you brought into notice of all of us, that our clinical examination has to be thorough. And this has come to my notice also, that most of the time we are doing PET CT rather doing a proper thorough examination, which is
After the examination, if you want, of course, for restaging, distant metastasis, this, that, you will need a PET CT. I don't have anything against that. Actually, for suspected recurrence, the diagnostic performance is even better. If you suspect a recurrent disease based on either symptoms or clinical examination, then the performance of PET CT for staging, for proving cancer, for staging is much higher. So, but clinical examination cannot be supplanted. We should not just say then just get a PET CT, then we'll see.
A thorough clinical examination supported by PET CT would be the way to go.
Yes, yes. And in certain situations, I think a local MR is also very important, particularly tongue, waist tongue. I think MRI, because if you have to take decisions regarding surgical salvage, I think MR becomes much more important. The resolution, the PET cannot match the resolution, the soft tissue extensions that you see on the MR.
So you suggested in those cases we do a MR rather than a PET CT, or you say we have to do both MR along with PET CT?
Yeah, so I think both are complementary investigations. They are not competing investigations. Your MR is required for local extension to plan your surgery in a better manner, but your PET CT will be required whether you need, if there is distant metastasis, then of course you're not going to do a surgical salvage. There is increasing evidence that so in TMH, our practice has been whenever we do surgical salvage for the primary site, always an ipsilateral neck dissection is done. I am not so sure whether that is always required. If there was no evidence of disease in the neck based on the restaging PET CT or plus minus the MR, I really doubt how many times, I don't have those numbers, but I think it might be a good idea just to see when we did a surgical salvage of the primary and we did a ipsilateral neck dissection, how many times did we find neck node positivity when the imaging was, clinical examination and imaging was not showing any lymphadenopathy.
Okay, so we are seeing this in organ preservation setting. So where the previous surgery has not been done, and after that we are salvaging the patient, right?
Yeah, that's what I'm saying. We've done definitive radiochemotherapy, then the patient comes with a suspected recurrence, or even suppose a residual disease at the primary site, biopsy proven, you did an EUA, took a biopsy, turned out to be residual squamous carcinoma. Now you want to do a TORS of the base tongue. Now if the neck nodes were clinically negative on FDG PET, they are not showing involvement in the post-treatment assessment scan. I am not so sure whether doing the neck dissection helps in that case. The data on that is very limited. The practice is quite variable. I think many surgeons in many centers do only surgical salvage of the primary site. They don't address the neck. I think most of the time the hypothesis is that, particularly in recurrent cancers, that the recurrent cancer could have seeded the lymphatics. Although in residual cancer following definitive radiochemotherapy, I don't necessarily agree that that may be the case. So I think Sarvani has her hand up.
Yes, sir.
Yeah, to this issue that you raised, Tejpal, the decision to actually do an ipsilateral neck dissection in the salvage setting is often dictated by the pre-treatment status of the neck. And as you correctly said, there are variable reports in literature, so much so that in some series, the incidence of positive nodes at neck dissection, even in the absence of a image positive neck, may be to the tune of almost 40%. So very often the decision to do a salvage neck dissection at the time of salvaging the primary is dictated by the pre-treatment neck status rather than by the post-treatment neck status. So there is no standardization of this approach actually. And even reports in literature vary depending on what was the stage of the neck prior to the chemo-RT.
No, I completely agree, but I think as a policy in TMH, we have been doing.
Yes, we've been doing the neck. We've been doing the neck unless it was absolutely N0 and there was nothing in the neck at all, even prior to doing the CTRT. Otherwise, we are as a policy doing neck dissection.
Yeah, so maybe a good idea for someone to really look at what primary sites have been. See, our primary surgical salvage may not be that I mean, those numbers
I
may not
think
be.
Shiva has done something towards this, if I'm not mistaken, because we very lately discussed it.
No, that I showed, Sarbani. That was the paper, 75 patients who had undergone a salvage neck dissection and comparison with histopathology.
Yeah, no, you're talking about Kuzema's paper. I'm not talking about that one. I'm talking about what happens when you do salvage. Yes,
yeah.
yes.
So I think that's a good thing to look at, that when we have done a salvage for the primary and done an ipsilateral neck dissection, how many of those patients did have positive neck, and go back to the imaging findings also, and just I think that would be a nice thing to look at.
So there is a paper by, I think, recently published by Devendra Chokar sir, where they have looked mainly into larynx. We know that larynx won't have too much of nodal metastasis usually. That retrospective review is there, means analysis, and they have seen that the patients, like Madam said already, that those patients who had pre-treatment nodal metastasis as compared to those who had N0 neck. So in those cases where the neck was N0 in the before the treatment, before the definitive treatment, they actually were negative even after the salvage surgery. So the interpretation was that the patients who have pre-definitive treatment N0 neck, and also the PET CT before the planning of the surgery, they can be we can just do the primary resection.
That is what I am also trying to say, that because this is, the practice is very variable across the globe. I mean, some people don't address the neck, some people routinely address the neck, and I think there has to be some algorithm by which the surgeons can sort of take those. I think a pre-treatment N0 neck with a post-treatment imaging showing no neck nodes. I think there is no need really to do a neck dissection.
Yes. I think we have some data to sir. Sir, I think there is one question. If you could please take that.
I can't see the question. What is the question?
Is there any diagnostic criteria for detecting chest mets during follow-up PET CT? In these cases, everyone is confused if it's infective nodules or mets. Often recommend follow-up scan or benefit of doubt to patients.
Difficult question. I think particularly in developing countries, including India, you get a lot of sort of granulomas and things like that, both in the mediastinal nodes as well as lung nodules. I think nothing to do with head and neck cancer in particular. I think if you find an FDG avid nodule in the lung or in a mediastinal node, there are criteria to define whether that should be considered as related to the index cancer or could be considered inflammatory. Generally, size and avidity are the two most common features that people use. However, if you get telltale signs of infection in the lung, so if there is clear evidence of tree in bud appearance, infective picture, then you have to clearly assume that that is related to the infection rather than to the index head and neck cancer in question. Also, importantly, if you have a pre-treatment FDG PET CT, that also helps. And in the study that I showed, the 60 patients of the Siemens trial, where we looked at initially the post-treatment response assessment PET scan, actually, if I remember correctly now, at least 7 or 8 of those patients did have something in the mediastinum, which we finally considered as that is unrelated to the index head and neck cancer. In India, it is very common to have tuberculosis, other granulomas, some infection. So I think it is a given that many patients will show some suspicious chest findings. I think only time can really tell you. There is no real if there is very strong suspicion, occasionally we've done an FNAC from one of the nodes to prove that it was not head and neck cancer that had spread. That is very occasional. Most of the time, in consultation with your nuclear medicine physician, you should be able to come to that answer.
So I think that because that's a routine problem, sir, we see like sub-centimeter nodule many a times. Even the radiologist and the nuclear medicine specialists may not be able to help us much with that. So I think in our routine practice, what we do is if it is a sub-centimeter nodule, equivocal, and the primary is resectable, so usually we go ahead and give it benefit of doubt, and we go ahead with the resection. If that is the only site we are not sure, biopsy is not possible. If it is a larger nodule which can be biopsied and as a higher suspicion, we'll try to go ahead and do the biopsy as you suggested.
Yeah, so I think surgical decision making becomes more difficult because if there is metastatic nodule, then your surgery is completely sort of redundant. For definitive radiochemotherapy, that may not be that much of a issue, but I think for surgery it becomes very important. You have to be really sure that you are not dealing with a metastatic disease upfront.
Right. So if there are any other questions, please ask them. You can ask them directly also.
I hope whatever was the sort of mandate and intention for covering this topic. I mean, I
Yes.
was able to do that, and it was helpful to all the residents and fellows.
I'm very sure, sir. It was very helpful. So I think if there are no more questions, we can conclude today's lecture. With this, I thank Tejpal Gupta sir once again for today's excellent lecture and teaching us on the several aspects of PET-CT, and in fact the various criteria other than NIRADS we came to know actually, sir, Hopkins and the other criteria in detail. So I thank you once again. Thank you so much, sir.
Thanks, Poonam. Thanks.
Huh?